We're going to go into Aidin and the life of Russell Graney, and that's really our focus of the conversation. And most importantly, helping people out there who have to make informed decisions with very little information, objective information at hand. Welcome, everybody. This is Gil Bashe, correspondent for Health Tech World. It's a pleasure to be with you today. And our very special guest, Russell Graney, who's the Chief Executive Officer of Aidin, an important enterprise. They're really at the forefront of using information to help all of us make informed decisions, probably about one of the most important decisions we make on our lives, the care for ourselves and people we love, especially when they've been visiting a hospital. Often those hospital visits are planned, sometimes they're not. But regardless, once people are in that acute setting, that hospital setting, there's a need for a secondary plan. There's a need to decide what our post-acute plan is, where we're going. Are we going to a rehabilitation center? Are we going to a care center? Are we heading home? Those are very important decisions, big decisions. And Russell and his team at Aidin are really creating the sort of information platform that can guide us along that journey. Russell, thank you so much for joining us and joining Health Tech World for this conversation. 9+ years ago, you launched Aidin Health. Today, you're working with major hospital systems, long-term care facilities, helping us make very critical decisions. But what was the catalyst for creating Aidin?
Yeah, I think I was in a really unique life situation. At around the time that I was starting Aidin, right before then, I was working in healthcare and learned a little bit about case management services through a private equity firm I worked at, and dabbled quite a bit in learning the world of healthcare. But it wasn't until my uncle was diagnosed with early onset Alzheimer's that same year that work became really meaningful to me. And I found myself on weekends meeting up with my aunt and my uncle in New Jersey, not far from where I live, and trying to make very hard decisions often. He would be in the hospital. We would need to choose a rehab, a home health agency, a hospice agency eventually. And the ironic lesson we learned was that the scariest moment of a hospital stay is not the rush to the hospital in most cases. It's actually the day of discharge and that moment of making these very important decisions when all of a sudden your loved one's care and healing is back in your hands. So those decisions are extra heavy, and going through that personally was a huge catalyst to try to reimagine what this moment feels like for everyone.
Your story about your uncle and supporting your family, having to make those decisions. I think that this is a conversation happening in countless homes around this nation, and will happen around the nation again and again and again. And I'm sort of amazed that when people are leaving a care setting, a hospital, to go someplace else, often in the post-acute care planning session, someone will say, here are 5 places I recommend. And at that point, we need to make a decision. And we're trusting that person in front of us who says, here are 5 places I think you should look at. What's the basis from your studying of this? What's the basis of how that information is collected in that setting where you have a case manager who says, here are 5 places, go check them out?
This is not an unusual situation. About 40% of patients leaving the hospital are going to need some sort of post-acute care. So many of us will find ourselves in this position with an aunt or uncle or a husband or a wife. And so it's important to know what's coming your way. One of the shocking things that I learned as a patient and a family member going through this 8 years ago was that the information, or I should say the dearth of information available to us as patients and consumers when it comes to finding a doctor, doing quotidian things that we all try to do, that same dearth of information exists on the enterprise side for professionals. So that case manager or that professional whose task it is to support patients with these kinds of transitions, they themselves are not provided with much information. We're reminded often that those case management staff in hospitals, they spend their days in the hospital. They do not work in nursing homes. They don't ever visit these locations. So it's very hard for them to have a sense of what's going on. So today, the way that that information gets presented to patients is really just a laundry list. Here's everybody who's in the area, all the providers in the county. They'll have some insight and some guidance around who maybe takes your insurance and doesn't. So there's certainly some guidance and expertise that will come with that list. But today, the approach to patient choice is kind of very, very low key, very dependent on patients to present with information and for them to make some difficult choices on their own. So when my family went through this, we looked at this list of phone numbers and addresses, and we thought that our job was to choose the provider closest to home. And that's actually what most patients do today. And as a result, most patients actually don't end up choosing the best quality provider. Fewer than 16% of Medicare patients end up going to the best quality provider in their area. And we now get about 30% of patients readmitted right back to the hospital within 30 days of going out to that post-acute provider. So understanding the information at play here is important to find the best outcome. And that's fundamentally where the Aidin approach starts to come into play.
Tell us a little bit about what sort of information you're aggregating, and how would I, as either an institution or a consumer, access that information in order to be more in the know?
What we've been doing for the past 9 years is working with some of the top health systems across the country to innovate around these information systems that exist. I'd say that there's really three main things that we bring into play. And one of them actually is a very big conversation that we hear a lot in the world of technology and digital health is interoperability. So the first thing at play here is actually just being able to get a patient's record out to the community providers to determine who even can provide the care that's necessary. So something as simple as sharing a patient's medical record, we all know is not simple. And that kind of one small piece of interoperability is the first piece of Aidin tackles. Now, the next two pieces I would argue are just as essential to what interoperability really means, but we don't talk about them a lot. Interoperability today is kind of information, just get the information from A to B. What we've done at Aidin is learn a lot about points 2 and 3 to actually make that effective. So step 1 is getting the information across. Step 2 is building uniform workflows that are shared across organizations. So a referral is an excellent example for something like this, where we have a case manager at a hospital working very closely with multiple intake specialists across different post-acute provider specialists. Those workflows and the work that's happening between those providers right now is different every single time. Gil, if you asked me how many steps does it take to place a patient into a nursing home, I couldn't tell you, because in most hospitals, it's entirely different every day. What Aidin does is introduce a standard process where we know that every time we're doing a referral, we can get everyone on the same page across organizations and get things done faster with deadlines and tasks and overdue notices. The third piece of what Aidin brings into play that adds on to kind of what interoperability really means is now with those standards, we can actually establish a reputation for you as an organization. We can establish that you are consistent in providing quality care. You are a good partner and responsive to clinical questions that come in. We can establish that you're someone that we can count on in the future. And as a result, now build into our ecosystem of how we actually engage patients with information to not only show them quality data and outcomes data, but also know that we're contacting all the providers who actually can offer a bed.
Yeah.
So, those three things combined are kind of what we turn what a conversation that's often called interoperability into what we call interworkability. We need to be able to exchange information, but we also need to work together around that information and understand who I can trust and who I can't.
Yeah, that interworkability, it's the practical nature. They say that all healthcare is sort of like household, is local. And while interoperability, obviously, we're trying to solve an infrastructure problem of the nation among fragmented systems, you're really trying to say, look, let's get real here and make it helpful for the people who have to make a very important decision. But it also sounds like by creating visible standards that people can participate in, it's a little bit like you're allowing, in a way, competition and visibility, transparency to raise everybody's standards. What's the reaction of people participating in the ranking system? Do you find that people who believe in their system are more inclined to try to sort of get involved with Aidin and say, we'd like to be ranked by Aidin. We think that we have what it takes. Are you that sort of, is Aidin becoming the JD Powers of continued care?
Yeah, absolutely. We introduced our concept of badges, is what we call different accolades that providers can earn based on their outcomes and their partnership. And those badges, I have been a ton of interest around them, and we get phone calls every day from providers interested in learning how to understand kind of what their rating looks like today. The value, I think, those badges is that they fit into an ecosystem where they matter. So one of the things that we see today is, when choosing nursing homes, most patients are choosing the provider closest to home because that's the information that they received from the administrator. It turns out if we present patients with different information around quality and outcomes, well, in the world of Aidin, 82% of patients choose the best quality provider simply because we engage them with that information. So providers are eager to engage with their scores because those scores matter in where referrals are sent and in how patients make choices. So a huge part of what Aidin is about is indeed rationalizing this part of the healthcare marketplace that today is really based on who's got the fastest fax machine and the quickest response time. What we want to do is turn that into a place where providers have more than just a fax machine and a Medicare star score to build their reputation around. So for high quality providers who are doing great in kind of established public measures we have available, they're eager to get on Aidin because it shows off all that information as well as their partnership data. For providers who don't have a 4-star, 5-star Medicare score, but are offering quality care to patients and delivering high patient satisfaction, reducing readmissions, responding on time and being a good partner, those providers also now have a way of recognizing and differentiating where they're offering quality care apart from others that's not just based on one number, which is really what we're operating off of today.
This is fantastic. How do you collect the information? It's uh, are people being asked to self-report, with transparency? Are you able to vet out the information? Tell us a little bit about the information collection process.
I think self-reporting is something that happens a lot in the world of Medicare data, and I think it's asking too much and too little of people all at once to ask them to self-report data that they know their business relies on. So we don't really do a lot of that. We do collect publicly available data. So Medicare does publish for quite a wide range of levels of care, decent information about how they're performing with patients. All of that data gets pulled in every month. But more importantly, what we're doing is actually using every single one of our transactions to learn an outcome. So every single patient that we place, that turns into a patient satisfaction survey score, that turns into a readmission survey. And that also allows us to track how is this provider doing as a whole for all of our hip replacement patients, for example, versus maybe our patients with neurological needs are better off being served at this other location. So starting to dig a little bit under the surface of some of the high level publicly available data to understand where are providers' specialties, where are their strengths versus their weaknesses, because we know that there isn't one provider that does everything well. The trick of the game is identifying who does what well and automatically steering our patient volume in that direction.
How, in terms of the site itself? I know that the site is suitable for mobile. Obviously, it's a great laptop, desktop site. But when you were designing the site itself and the information, how provider or consumer friendly was the site constructed?
Aidin is really an enterprise tool. It's used day in, day out by administrators at healthcare systems who have a very high level of complexity and sophistication and speed, honestly. People move quickly and are doing a lot at these big organizations. So that is one use case and one user profile that we design towards deeply, to be able to give very busy people tools that work quickly and effectively for them and help them do their job the way they want to do their job, really providing the best care to patients. That being said, we also have elements in the tool that are essential patient engagement tools. And in fact, a lot of our health systems are hiring us to engage their patients with this information. So it's a core part of what we offer. I'll say that after a lot of design and input, what we do at the end of the day is look at the outcome. So that 82% number I mentioned earlier of how many Aidin patients are choosing the best quality score, that's something that we keep our eyes on very closely. That tells us that all the information and design that we're presenting is helping people make the right choice. That being said, we look at our patient choice materials every year. Last year, there was a great upgrade to patient choice compliance requirements called the Impact Act that allowed us an opportunity to gather a bunch of our clients, show them the latest thinking on our patient choice list, and bring the community together to make sure that those edits were the best they could be. But I'd say that engaging patients and helping providers, again, differentiate and show off where their strengths are is a core part of what we're doing to help shift volume towards where it belongs.
Do you think that individual providers that are at, sort of like high volume professions where people do require post-acute care planning, post hip replacement surgery, post cardiac surgery, for instance, um, are they finding that they want to be more involved in the care next step care recommendation process, or are they still comfortable, thanks to Aidin, perhaps, delegating that off to the sort of the discharge planning team?
There's a lot of new payment structures. Bundled payments, obviously, is a big one. Really saving together the outcomes and looking together at this entire episode of care across different levels of care. So indeed, yeah, we do see a lot of providers getting more engaged in managing where their patients are going once they leave their care. That is a challenge. Today we have health systems who put in place partner provider networks and struggle to get volume into those networks. I think that there's a couple of things here. The first item at play is really that open competition component is essential to build up from the workflow level. So if you're using tools that only your friends and partners use, and if not 100% of your patients can go to those partners, you haven't solved the core problem for your staff members. So I think a big part of our approach here at Aidin is to be backwards compatible. So our clients often are the most forward thinking, the most electronically connected folks in their area. And that's great. They take great advantage of that. That does not mean that all of the home health agencies in their area are the same. And that also doesn't mean that they shouldn't be able to all work together. So a core part of Aidin's kind of nitty gritty referral support and workflow support is enabling one of our users on a computer or a laptop to be able to speak with a provider who's still working off a fax machine or off of email. So that backwards compatibility is huge to being able to generate the kinds of insights and data that we need as a population, as an entire healthcare community, to get a better sense of seeing how are we doing as a whole. This is no longer siloed care. We're looking at entire journeys. And so to be able to track that information and all work together, regardless of setting, regardless of where this patient is going, regardless of payer, those are all new ideas, but fundamentally they are possible. We are doing the work today. We just need someone to track it and show it back to us.
It's fantastic. I know that you have been diligent the last year in putting in place more leaders, putting in place operational infrastructure, freeing yourself up as the visionary and chief executive to look at the future of this category. Would you mind giving us a peek at your crystal ball at what Aidin is going to look like at its 10th anniversary? You're celebrating your 9th now. Next year is the 10th anniversary. Congratulations in advance. Where do you want to see this going? Where is the category going? And what role will health information technology play in creating a healthier America?
Mm. There is no dearth of innovation and energy around healthcare in America, and it's a great truth that has always been the case. What I see as an opportunity for us to make the most of all of that investment and innovation is to build the infrastructure that allows us to discover it. An analogy that sometimes I think of, and I'm dating both of us, Gil, with this one, but we remember the internet pre-Google.
We
And what it
do.
looked like to be on a GeoCities site trying to find a piece of information that you're looking for. It was hard. It was hard to find what you needed until Google came around and thought of a whole different algorithm for the way to rank information, such that when you type in your search, really the most relevant stuff shows up first. And what that did for the internet was enable people to make good websites and to reward people who are making good content on the internet with the eyeballs to receive that content. I think of Aidin as doing the same thing in healthcare. We have a lot of web pages. We got a lot of providers who are doing great work and doing a lot of innovative work to improve healthcare delivery. but we don't have a system or an infrastructure that allows us to discover them, to reward them with more patient volume, to educate patients on the things that are available. We're a little bit blind. And so Aidin, as we go about the very core work of referrals and authorizations and nitty-gritty workflows that power healthcare every single day, the benefit of that work is that it builds for us that map, that ecosystem of all of these providers working amazingly in tandem, despite all of the barriers, despite all the challenges that face them today. And at Aidin, our mission is to remove those barriers such that all of that collaboration can be seamless and fun, and our marketplace for healthcare can be really properly functioning.
Russell Graney, on behalf of the health tech world community, I want to thank you so much. You are, through your work, making things interworkable for all of us, for ourselves, our households, our families, and for a very fragmented health ecosystem. Information you've demonstrated is life-sustaining power. Thank you, continued success. Thank you for joining us on Health Tech World.
Thank you, Gil.
I often have said to people prior to this world, best to go home and hire a nurse. You're better off, and bring in PT into the house. At least you can eat the meatloaf you want to eat as opposed to their meatloaf. What Russell and information and others are doing with post-acute care planning and population health management, I believe, is they're actually creating the infrastructure of care.